Hi everyone, I'm Dr. Mallika. Welcome you all for the Facebook live session. Here we have Dr. Ram Prahlad sir, one of the best medical oncologists in Guntur. He has over 8 years of experience in the field of medical oncology. He won gold medals in MBBS and MD General Medicine. He also published several papers and delivered professional talks in various scientific forums. He is a member of several prestigious medical institutes and associations. Today we have Dr. Ram Prahlad sir to discuss about urinary bladder cancer. We welcome you sir on behalf of AOI Guntur.
Thank you, madam. Today we are going to discuss about urinary bladder cancer, which is one of the most common cancer in the genitourinary tract. So this cancer presents with various symptoms like hematuria, and there is different presentations, and let us discuss about that.
Sir, first of all, what is urinary bladder and urinary bladder cancer?
So urinary bladder means, first of all, whenever whatever food or liquid which we take, that is getting filtered in our kidneys, and that is being excreted through our genitourinary system. So the storage organ of the urine is called as urinary bladder, where the urine is getting stored for a few hours, and after that, whenever we try to feel the urge, then we try to avoid it. So before avoiding out, the storage organ is called as urinary bladder, and this urinary bladder, whenever there are rapid multiplication of cells uncontrollably, lead to urinary bladder cancer.
So what are the risk factors for urinary bladder cancer?
So the most important concept regarding cancer is cancer occurs due to the chronic irritation in our body. The most common cause of urinary bladder cancer is the chronic smoking. The other common causes are chronic irritation due to one of the parasitic infection called as schistosomia, which causes squamous cell carcinoma, and exposure to the chronic carcinogens like aniline dye, and the history of family like Lynch syndrome. So these are a few causes of the risk factors for causing urinary bladder cancer.
So what are the main symptoms of urinary bladder cancer?
So the most common and presenting symptom of the urinary bladder cancer is painless hematuria, means the passage of the blood in the urine. So it can be gross hematuria, and also certain times it can be microscopic hematuria. This is the most common symptom of the urinary bladder cancer. Other symptoms can be a pain in the lower abdomen, and also there can be symptoms like frequency, urgency, hesitancy, and also certain times there can be fever due to urinary tract infection, and there can be abdomen pain also.
So what investigations will you advise in urinary bladder cancer?
So whenever a patient is coming with a gross hematuria or a microscopic hematuria, so we need to evaluate the patient in lines of what are the common things that are there and what are the rare things like urinary bladder cancer. Whenever we are suspecting urinary bladder cancer, so first we should do a general investigations like the complete hemogram, renal function test, and also the liver function test. So we need to know whether the renal kidneys are normal or whether there are any problem in the kidney. So then the primary gold standard investigation in the case of evaluation of urinary bladder cancer is cystoscopy. Cystoscopy means there is an instrument which we send, an endoscopic instrument which we send into the urinary bladder, and see what is there in the urinary bladder, whether there is any growth is there or whether there are any changes are there in the urinary bladder, that can be visualized with the cystoscopy. This is the most important and gold standard investigation in evaluation of the urinary bladder cancer. Once we are finding something abnormality in that, so we try to collect the urine, and also we do the analysis for the malignant cytology. It is called as urine for cytological examination. And the other thing is we need to take the biopsy. So we need to take the biopsy of the growth that is there and other abnormal structures or abnormal findings which are there in that urinary bladder. That confirms that the patient is suffering with urinary bladder based on the histopathological examination. Which histology? It could be the most common histology which we see in the urinary bladder cancer is transition cell histology. And the rare histologies can be adenocarcinomas, squamous cell carcinomas, urachal carcinomas, and other things. So that completes the initial workup like that to confirm the what is the diagnosis, what is the histopathological examination. After the histopathological examination is being done, we need to stage the disease. So we try to do the MRI of the abdomen and pelvis to know whether what is the local stage, whether the patient is having a very localized stage, or whether it has been spread to the regional structures, or whether it has spread to other structures like. So after that, we try to do the other investigation like CT abdomen, also CT chest, whether there are any spread to the other organs like the lung, liver, bone, and etc. So the bone specifically, we try to do the bone scan. If the patient in the liver function test, the alkaline phosphate level is very much elevated, so that may show any lytic lesion of the bone due to the spread of the urinary bladder cancer to the bone. And the latest is the PET CT scan. With a single scan, we can get a total information of the growth of the urinary bladder and also the spread of the urinary bladder to the different organs like the bones, kidney, liver, and other vital structures of the body. So this completes the how to investigate. First, we need to do the general investigation. We need to then confirm the urinary bladder cancer, and after confirmation, we need to stage the urinary bladder cancer, and basing upon the stage, we start our treatment basing on that.
So based on biopsy, how can we divide urinary bladder cancer?
So the most common procedure we need to do to establish the diagnosis is the biopsy. So the procedure that is called as to do the biopsy is called as TURBT. It is called as transurethral resection of bladder tumor. So whenever there is a bladder tumor that is there, so we need to remove the tumor, and also we need to remove certain structures in the urinary bladder so that we know what is the extent of growth of this urinary bladder, because that decides the plan of treatment. So most of the 70% of the urinary bladder cancers are non-muscle invasive. Means what is muscle invasive, what is non-muscle invasive. Before that, we should know what is the T staging of the urinary bladder. So urinary bladder cancer is divided into 4 T stages. Like T1 means the involvement of the mucosa and also the submucosa in the urinary bladder. Okay. Whereas T2 means involvement of the muscle. Involvement of muscle is called as T2 stage. When the urinary bladder cancer is involving the perivesical fat, that is the outside fat, then it is called as T3. Whereas T4 means involvement of the other regional structures like prostate and other things, then it is called as T4. Whenever the urinary bladder is involving the mucosa and submucosa, that is called as non-muscle invasive bladder cancer. Whenever that is involving the muscle, that is called as muscle invasive bladder cancer. So broadly, these are divided into non-muscle invasive and muscle invasive. So certain times in muscle invasive, that can spread to other distant organs, and that can also metastasize.
So what is intravesical therapy?
So intravesical means the meaning is, so giving any treatment directly into the bladder is called as intravesical therapy. So this comes into the role whenever the patient is having an non-muscle invasive bladder tumor. Okay, so means the muscle is not getting involved; it is involved only in the superficial layers of the urinary bladder. Whenever there is a non-muscle invasive bladder tumor, in order to prevent the chance of recurrence in the urinary bladder, we try to give certain immunotherapy drugs or certain times chemotherapy drugs directly into the urinary bladder. So certain times we try to give the BCG vaccine directly into the urinary bladder to prevent the recurrence. That is called as intravesical BCG vaccination. Certain times we try to give the chemotherapy drugs like gemcitabine or mitomycin or epiribicin directly into the urinary bladder, and we try to infiltrate into the urinary bladder and change the position of the patient in different, so that it can spread to all the regions of the urinary bladder effectively in order to prevent the further chance of recurrence in the urinary bladder. This is called as intravesical therapy. Intravesical means giving any form of treatment directly into the urinary bladder is called as intravesical therapy.
So what is intravesical BCG treatment?
So the first immunotherapical treatment started in the management of the urinary bladder. So what happens is, whenever there is a non-muscle invasive bladder tumor, so we try to remove that tumor. So then we have a chance of recurrence in that tumor. So in order to prevent the recurrence, we try to give intravesical BCG. So we try to keep a catheter into the urinary bladder and give the BCG vaccine of 80 mg and we try to rotate the patient in different directions so that the vaccine is being reaching to every corner of the urinary bladder, and we should ask the patient not to take any fluid for about 2 hours, and this vaccine is being rotated in all the regions of the urinary bladder. So this vaccine is given every weekly for 6 weeks continuously. This is called as induction therapy of the BCG vaccination. After induction therapy, basing on the response we see, so we need to give a maintenance therapy. So maintenance therapy is given for about 3 years. Means for every 3 years, it is given like every 3 monthly. Like first one 3 months, 6 months, 12 months, 18 months, 24 months, and lastly 36 months. So in every month, like in the maintenance period, we try to give weekly for continuously 3-week duration. So that total duration of treatment lasts for 3 years, and it consists of 6 weeks of induction therapy followed by maintenance therapy with BCG vaccination, so that we are to prevent the further recurrences of the urinary bladder cancer.
Sir, when do you consider surgery in non-muscle invasive bladder cancer?
Okay, good question. So the important thing is in non-muscle invasive cancer, we try to do the TURBT, just try to remove the tumor, and we try to give intravesical therapy, whatever that is available with us and whatever the patient is comfortable with us. So certain times we need to go for radical surgery in case of non-muscle invasive. Like the patient can have a CIN, that is called as carcinoma in situ, which is a high risk feature where there are chances of recurrence in these patients. Certain times the patient may not respond to the BCG vaccination which we have given, and there can be growth there in that condition also. Or sometimes the patient can have a recurrence that we need to give do a radical cystectomy. And certain times the patient may have a multifocal lesion. Patient not only in a single site and also in multiple sites there can be tumor which is not amenable to TURBT and also the intravesical therapy. Certain times there can be a T1 lesion which is high grade, which is very much infiltrative and which cannot be removed with a single surgery also. So these are few conditions where we go for surgery in case of non-muscle invasive bladder tumor. Generally we do a TURBT followed by intravesical therapy, either chemo or immunotherapy, whichever the patient prefers. So only in case of resistant conditions or recurrence conditions or big lesions or multifocal lesions, we try to go for the radical cystectomy procedures.
Sir, what surgeries do you consider in urinary bladder cancer?
So the most common surgery that we try to do in the urinary bladder is the removal of the bladder tumor, that is called as TURBT. So which is done with a cystoscopic procedure where we try to remove the tumor, and also we try to remove the layers of the urinary bladder so that we know the invasiveness of the bladder tumor, whether it is a muscle invasive or a non-muscle invasive. This is a common therapeutic procedure that we try to do. So other procedures, surgeries that are done are the partial cystectomy, which is commonly done whenever the urinary bladder is getting involved in the dome of the urinary bladder, or it can be an urachal carcinoma that is there. So where we try to remove only the partial of the urinary bladder. Whereas radical cystectomy is done from the stage from T2 to T4A. So in that we also remove the urinary bladder and also the surrounding structures that are there, so that we know not only the urinary bladder, we also know the entire status of the other structures and also the lymph nodes that are there, so that we can get an idea how to give the adjuvant or any form of other treatments there.
So when do you consider only radiation therapy?
So radiation therapy, that is an important question, because urinary bladder cancer generally occurs in the patients of age of more than 60 to 70 years or certain times in 80 years. So the most common fear that the patients do have is radical cystectomy. So if you remove the urinary bladder, we need to keep some other structure in the abdomen, so that the urine should be leaking through the abdomen wall. So that is panicky to the most of the old individuals, and certain times the patients also are not fit to undergo this major surgery. So in that condition, whatever we do is we try to remove the urinary bladder tumor, which is called as TURBT, and we know whether the patient is having a muscle invasiveness. We try to give a tri-modality treatment called as cisplatin with a platinum group of chemo with radiation. So these three things, removing of tumor and also giving chemo and radiation, that is called as tri-modality treatment, is given in order to preserve the urinary bladder in the old patients. So the patients who are not fit to go undergo surgery, or patients who are denying surgery due to their age, are considered for the surgery of the urinary bladder with removal of the TURBT and also the radiation. So there we try to do only the radiation part.
So when do you consider neoadjuvant chemo?
So neoadjuvant means whenever the concept of neoadjuvant comes whenever the size of the tumor is large or the patient has a muscle invasiveness. So in that condition, we try to give neoadjuvant therapy. So as I said in the initial T stage, like T2, T3 and T4A. So where the size of the tumor is large and where the surgeon is not comfortable to remove the tumor en bloc in a single go. So there we try to give the neoadjuvant chemotherapy. And certain times the patient can have a T2 lesion and also there are lymph nodes also. So in that condition also we try to downstage the tumor and by giving the neoadjuvant chemotherapy. The most common neoadjuvant chemotherapies that are followed are MVAC regimen and also gemcitabine and cisplatin based chemotherapy. Whereas MVAC consists of the methotrexate, vinblastine, adriamycin and cisplatin. Whereas the gemcitabine cisplatin consists of only two group of drugs. It can also be given as in dose dense form also. So the main concept is to decrease the size of the tumor so that it increases the operability of the tumor.
And when do you consider adjuvant chemo?
So adjuvant has a two important components like adjuvant chemotherapy and certain times adjuvant immunotherapy also. So whenever we are doing a radical cystectomy from the T2 size, T2 lesions onwards, or whether any lymph nodes are involved, or whether the T3, T4 structures, there are high chance of recurrence in those tumors. So we try to give the adjuvant chemotherapy in the form of gemcitabine, cisplatin, or a MVAC regimen, basing on the renal function of the patient, performance status of the patient, whether the patient is having no neurological deficit or the paresthesias, or the patient doesn't have any hearing problems and other things. Considering all these, we try to give the neoadjuvant chemotherapy in the form of MVAC or gemcitabine cisplatin. Certain patients are having renal dysfunction. In that condition, we try to replace the cisplatin with carboplatin. This is the form of treatment that is given as adjuvantly. So certain patients may receive neoadjuvant chemotherapy, and after the neoadjuvant chemotherapy, they have undergone surgery there. In the surgery specimen, they may have a residual disease. In that condition, that indicates that the tumor resistant to the chemotherapy. In that condition, we try to give the adjuvant immunotherapy in the form of nivolumab for 1 year, so that it has a high chance of preventing the recurrence. So certain patients are not fit for the chemotherapy or the carboplatin based therapy. They can directly go for the adjuvant immunotherapy with pembrolizumab also.
So what is stage 4 bladder cancer?
Stage 4 bladder cancer is a big terminology. Any stage 4 means involvement of not only the bladder and the surrounding structures, but also it has a spread to the distant organs like the bone, the liver, the lung, and other vital structures of the body. So any tumor which has spread beyond its boundaries and to distant organs, it is called as stage 4 cancer. So in order to evaluate for stage 4, we try to screen the whole body with a PET CT or the bone scan or the CT scan abdomen or the CT scan chest, so that we know what exactly the spread is and which are the organs that are getting involved and how to treat those organs like.
So can you explain the role of immunotherapy in bladder cancer?
So immunotherapy, the basic concept of immunotherapy in the bladder cancer has come with the BCG vaccine. BCG vaccine is nothing but a form of immunotherapy which we try to give in case of non-muscle invasive bladder cancer for nearly a 3-year period. So latestly the immunotherapy has come into the role in case of the stage 4 cancers, also in the adjuvant management of the cancer. So like that, we have the adjuvant nivolumab in the patients who are given a chemotherapy where there is a residual disease in the post-op histopathological examination. We try to give the nivolumab as an adjuvant for 1 year duration. So that is one form of immunotherapy that we try to give as an adjuvant form of treatment. Whereas in the metastatic setting, where the patients are very fragile and they are not interested in chemo, or they are having certain toxicities with the chemotherapy, we try to give the adjuvant as a palliative immunotherapy with pembrolizumab as a group of drug. Certain times after giving chemotherapy, when the patient is having a complete response in case of stage 4 cancer, we have a concept of maintenance immunotherapy with ipilimumab group of drug. So we have a immunotherapy in a broad aspect, like the non-muscle invasive, in case of muscle invasive as a adjuvant form of treatment, when patients are given a prior neoadjuvant chemotherapy and who have a gross residual disease, and also in the metastatic setting where the patients are not fit to take chemotherapy, and also in the maintenance therapy and avelumab in the stage 4 setting. So we have a broad concept of immunotherapy in the management of urinary bladder cancer.
So what side effect can we expect after chemotherapy?
So generally we have a gross different side effects that we have with chemotherapy. That depends on the type of drugs which are giving. So we have a 4 to 5 group of drugs which are given, like the methotrexate, the vinblastine, the doxorubicin, and also the cisplatin. So whenever we are, and also the gemcitabine part. So whenever we are giving chemotherapy, we should explain what are the general side effects of the chemotherapy, like the hair loss, the oral mucositis, the difficulty in deglutition, and also the oral ulcers, and any decrease in the counts of the blood cells causing neutropenic fevers, and loose stools, vomitings, diarrhea, and also abdomen pain or severe myalgias, and severe other side effects like sepsis and all those things. So these are general side effects that can occur with any group of drug. If we see the cisplatin as a group of drug, it has a common side effects like renal failure and also the ototoxicity, which we need to explain to the patient, because elderly patients are already may have a certain amount of sensory neural hearing loss, and when we are giving this cisplatin group of drug, there can be lead to total permanent deafness to the deafness due to this drug. So that is due to the cisplatin. Whereas with case of gemcitabine, it has one of the peculiar side effect called as hemolytic uremic syndrome as one of the peculiar side effect. Whereas doxorubicin is cardiotoxic drug, so which we need to explain to the patient, because the patients are most of the times elderly patients, and they can have a chance of cardiomyopathy due to the doxorubicin. And also we have the methotrexate, which can cause severe mucositis and bone marrow failure also. So these are the grossly the side effects of the drugs that we are giving in the management of the urinary bladder cancer.
So what kind of food precautions to be taken while on chemo?
So the food precautions are the most important thing which we need to follow, because whatever food we are giving or taking, that replicates in the well-being of the individual. So there are many superstitious concepts like not to take any food or other things. So if you do all those things, there can be severe malnourishment and also severe weakness or apathy to these patients. So we have to take the food. The food should be in the form of very soft. We should consist of less of the chilies and also the masala part. And also the important part is we need to take the food in regular intervals, like every 2 hours or 4 hours, so that the patient may not feel that the patient is having a large gulp of food, which he finds it difficult to digest. And also the food should be very soft, and it should consist of the most of the times a protein, like the protein in the form of egg whites or the soya and all those things. So that should consist of, and also the plenty of water should be taken, and the meal should be in frequent intervals of time, and fruits like thick skinned fruit should be taken, like the watermelon, the tarboos and all those things. So we have to follow these food habits so that the infectious things that are there on the surface of the fruits may not enter into our digestive system and doesn't cause any diarrhea. So food precautions should be aptly followed so that it doesn't cause any side effects due to the food, leading to the diarrhea, and also that can lead to hypotension, also sepsis. So we should always explain the patient in detail what is the diet that they need to take in the daily thing, so that a simple mistake can cause a lot of loss to the patient.
So what is the role of PET CT scan in bladder cancer?
So generally we don't do a PET CT scan in a bladder cancer, but whenever the patient is having a locally advanced bladder cancer, that is the T3 or T4, where there are chances of getting metastasized to distant organs or more, we try to evaluate by doing a PET CT scan. So we try to see screen from the top to bottom So regarding the whether what is the spread of the this urinary bladder tumor, like it can spread to the bones, it will cause a severe backache, or it can cause to spread to the liver, can cause a jaundice, or it can spread to the lungs, it can cause severe SOB and all those things. So the single evaluation of PET CT can give a complete information of the localized bladder tumor, how it has spread, and also the distance spread to the different organs like the bones, the liver, and the lungs, and other brain also in very rare circumstances. This is the information that we can get from the PET CT, because it consists of two important components, not only the PET but also the CT. The CT also gives a information regarding the brain also.
So finally, what precautions to be taken to avoid this cancer?
So what I say is we have to avoid irritation. So the most common irritant that we have is the smoking. If we avoid smoking 90% of the times, we avoid this cancer. And also, like sometimes the patient can have a bladder tumors, or the patient can have a recurrent urinary tract infections due to atonic bladder or certain other debilitating illness. So if we take those precautions and we try to remove those, like in the bladder stones, if they are there, if you are removing those bladder stones, so there is a irritation will be decreased, and there are chance of getting bladder tumor are decreased. So try to avoid irritation, like avoiding smoking, and also the precipitating factors which are causing the irritation. So if we try to avoid these things, definitely we can get rid of the bladder cancer. My most important thing is to avoid smoking. Smoking is a major concept of getting the bladder cancer. And also certain times there can be chronic carcinogens which certain patients are getting exposed in their industries, like the aniline dyes and all those things. So we try to screen them in a regular fashion, so that it can be diagnosed as early as possible, and avoid a major catastrophic to the patients.
Thank you, sir, for sharing your valuable information on urinary bladder cancer.
Thank you, madam.
Thank you.